Hi. Looks like everybody's getting on. Hi, everybody. Thanks for coming. I'm going to give one more minute for people to get on. As right now, looks like a lot of people are still getting their sound up. Give it just a couple more seconds. All right. I'm going to go ahead and get started. It's just a few minutes after 1. As we start, I just want people to know if you have questions, it's probably easier to put them in the chat function, and Cindy will be monitoring the chat function and can find a break in the discussion in which we will get to your questions, but I definitely want to hear them if there's something that you want to talk about. Also, in the chat function, you will find the link in order to get your CNEs. When you click on that link, you need to use Google Chrome. It will not work in Internet Explorer. And when you click on the link, you'll need to fill out the questions and either print it, save it, take a picture of it, do something in which you can prove that you were here, and then hit submit. If you hit submit, we won't be able to get you back to it. Also, this is being recorded, so I just wanted everybody to be aware. All right, I wanted to take some time and really talk about hemorrhagic shock in the trauma patient, seeing that that's our bread and butter. And if you've done any of my shock lectures before, you know my definition of shock is very simple. It is oxygen supply is not enough to meet the body's demand. And when we cannot meet the tissue oxygenation demand of the body, we go into shock. So it's pretty simple definition, but it kind of works for me. Now, the patients that we see that are at risk for hemorrhagic shock, we have trauma patients, GI bleeds, and the OB patient. Luckily, we don't deal too much with the OB patient, but we definitely have seen hemorrhagic shock and our GI bleeds that have come in, and then, of course, our trauma patients. So for this talk today, obviously, we're going to focus on trauma because that's kind of what I do. So trauma, it could be an MVC, it could be somebody getting hit by a car, an ATV crash, a shaken baby, kids that fall out of the windows, somebody gets a knife in the gut, and of course a gunshot wound, and multiple other ways we see kids come in that are going to have potential bleeding and hemorrhage. And sometimes we see it, it's pretty easy. It's a lot of blood on the floor. You have a lot of external bleeding, like with this guy right here. It's obvious that he is losing some blood. We have it squirting and holding pressure, but it may not be as obvious. A lot of the kids we see are having internal injuries that it takes a CT scan, like with our abdominal injuries or our head injured patients, and then potentially even some at the vascular level that we can't appreciate or may just appreciate by a bruise. When we see this, what's really happening in the body? Well, when we go into shock, we have to go back to the cellular level. The cellular level all starts with glucose. And of course, when we talk about glucose, we go into the subject that everybody loves to talk about, and that's the Krebs cycle. And if we get that molecule of glucose, enough oxygen, all of it that the body demands, the Krebs cycle is going to happen. And the outcome at the end of that Krebs cycle is that our body is going to have 32, 33 units of ATP. And we're going to be in aerobic metabolism. And that's where we want our body to be. But now when we have that same glucose molecule, if I'm not getting enough oxygen to that glucose molecule, the Krebs cycle is not going to happen. And the result of that is going to be only 2 ATP plus this little bonus of lactic acid. And that's really when we're in an anaerobic metabolism. So shock is all about being in an anaerobic metabolism with a little lactic acid on the side. Now this is going to be important because ATP is what gives all of our cells energy. It's the food for the cells. If our cells are going to grow, they're going to work, they're going to replicate, they're going to do what it is they're supposed to do, they have to have enough ATP. And at the very minimum, they need enough ATP in order to maintain that cell wall integrity. Because if that cell wall breaks down, now we go to what you would love studying second most in school, is the sodium-potassium pump. That cell wall breaks down, then the sodium-potassium pump doesn't work. When that sodium-potassium pump doesn't work, all those ions on the outside, which you know so well as your BMP, all try to equilibrate with the ions that we see on the inside of the cell. Now, I want you to look at the ion concentrations both outside and inside the cell, and notice that none of them are at a 50-50 ratio. So when they try to maintain an equilibrium, bad things are going to happen. Your sodium is going to, basically it's outside the cell, it's going to move inside the cell. So on your BMP, your sodium is going to drop significantly. Water is going to follow that. And so now we're going to have kids that have potential seizures. Your potassium is going to try to equilibrate. So all that potassium on the inside of the cell is going to move to the extracellular space, causing us to have cardiac dysfunction. So bad things are going to happen. We want that to stay together, because when our patients, our trauma patients get shocky, the result is the trauma triad of death. And what happens is our patients are going to start bleeding. The result of that is that lactic acid buildup because of the anaerobic metabolism. And so obviously with all that lactic acid, they're acidotic. Being so acidotic is going to decrease your heart function. The patients are going to be cold. Between the decreased heart function, the lactic acid buildup, the hypothermia, now coagulation slows down, and our trauma patients are coagulopathic. So that trauma triad of death, acidosis, hypothermia, and coagulopathy are all kind of this vicious circle that we need to recognize hemorrhagic shock and pull our patients out of. If we look at what does blood loss look like, there's obvious blood loss. We're not going to miss this. We're not going to miss all the blood on the floor. And we're going to be able to do external pressure, tourniquets, things like that. This is measurable blood loss. It's easy for us to see by the eye and know exactly what we're dealing with. But unfortunately, a lot of our kids in hemorrhagic shock are going to be kind of hidden blood loss. So we can look for things like seatbelt signs or bruising, maybe plank bruising for renal injury. We can feel the belly and see if it's tense or distended. Now that belly, that can hold 100% of your blood volume. And so we may have kids hemorrhaging into their abdomen and losing 100% of their total blood volume, and we may not catch it right away if we're not diligent about looking. We can also see a lot of blood loss with osteo injuries, femur fractures, like this picture on the left. Femur fracture, if you start bleeding, if it hits that femoral artery, you can hold about 60% of your total blood volume in the soft tissues around that bone. And then of course, pelvic fractures. The pelvic fracture, not only do we have vessels that are at risk of being torn, but just the osseous bleeding of the pelvic bone itself can cause a lot of hemorrhage. And so again, just like the abdomen, the pelvis can hold 100% of our total blood volume. So you can see with these injuries how kids can bleed out without ever making a mess. And then of course we have our head injured patients with our subdural and epidural hematomas. Now, unlike our abdominal injuries and our osseous injuries, the head is not going to hold near as amount of blood, and so we really won't see a lot of kids with just a TBI having issues with their H&H or with hemorrhagic shock. So really simply, trauma patients are going to lose whole blood from their injuries. We don't lose component therapy. We're not going to lose some platelets or some red cells. It's going to be whole blood. And we can lose up to 25% of our total blood volume and compensate for that blood loss. If we lose more than 25% of our total blood volume, now we're going to see patients in uncompensated shock. So you can see the importance of identifying hemorrhage early and being able to attack it. And what we're really looking for at the beginning is really a decrease in preload, empty heart, and not enough blood volume in our vessels. So what exactly is 20% of our total blood volume? I answer this by using Diet Coke because it makes sense in my mind, and it's something that is easy for me to look at a patient and think, okay, how much Diet Coke would you have in your body? And so I've kind of mapped it out. Of course, keep in mind that this is approximate. Not every child is going to be exactly where I tell you. If you look at some of the calculators to estimate total blood volume, it's about 34 milliliters per kilo of blood that you have until you get to be at about an adult size and it out. So our neonates have about 80 mil or a mini can of Coke. Our young child is going to have a liter. Your adult is going to have 2 liters, and you can see school age and infant in between. So I don't know if that helps anybody else, but it definitely keeps it straight in my mind. Now, if I have an infant and they're going to lose 25% of their total blood volume and not compensate anymore, that's starting to get bad. It's not going to make a big mess on the floor because it's only about 30 mils. It's not even a full cup of coffee that I'm going to dump over. And so we can't rely on just eyeballing the blood loss. Now, in compensated shock, our body is going to compensate when we have less than 25% total blood volume loss by using the sympathetic nervous system, by shifting fluids. It's going to use our kidneys to kind of keep fluid in our body, and then, of course, the inflammatory response. There's things we're going to spend time on today, and the key to really early treatment in hemorrhagic shock is focusing on what the sympathetic nervous system and fluid shift is going to do to help us with our compensation. And so let's start with the autonomic nervous system, which to me is the yin and the yang. It's the sympathetic and the parasympathetic system. And what's really going to happen, I like to look at those as the gas and the brakes to the body. The sympathetic nervous system, that's the gas. We hit that, everything goes into high, our pupils dilate, our heart rate goes up. Where the parasympathetic, everything kind of slows down. We become bradycardic. We become a little more listless. So that sympathetic nervous system, we also refer to as that fight, flight. Yeah, I guess I put it on there wrong. Anyway, what's happening is you have a secretion of adrenaline and noradrenaline. So epi is released in your body. Dilated pupils. We have vasoconstriction. Kids get dry mouths, tachycardia. Peristalsis is going to shut down, and our body is going to start releasing glycogen stores. So I really want to focus first on this vasoconstriction and tachycardia. And honestly, the dilated pupils, the dry mouth, the peristalsis, that's kind of, in our background. But vasoconstriction and tachycardic is what is going to give us all the signs and symptoms. It's going to help us totally recognize that we have a patient that's losing blood that could be in trouble if we don't recognize it soon. Now, the hard part about pediatrics and tachycardia is why are they tachy? It could be because of the sympathetic nervous system, the fight-flight. But we also see kids that are tachycardic because they're scared and they're in pain. And we see it just based on the blood loss alone, that just decrease in preload, plus or minus that sympathetic system. And with the trauma patient, especially early on in their care, all 4 of these things come into play. So there's a lot of reasons for tachycardia. As far as the vasoconstriction, the early signs of vasoconstriction is basically our vessels get so tight, it clamps down on everything else. So we have cold mottled skin with poor peripheral perfusion. And one of the first things I always do when I assess these patients is I feel a radial pulse or a pulse in the foot. And if I can feel those distal pulses, I know my kid's doing just fine. But if I have absent or weak pulses, now I know we're vasoconstricting, and so it's really an early sign of compensation. Same thing for decreased urine output. The less urine, if I'm not making urine, a lot of times with hemorrhagic shock, it's because I don't have any volume in which to make it. And then, of course, there's altered mental status. I find altered mental status with kids sometimes difficult in order to assess because, sometimes they're agitated or scared. And that makes us, we can chuck it up to agitated or scared versus lack of oxygen, which is what's happening with vasoconstriction. And we can get ourselves in trouble if we start making what I consider valid excuses and we don't consider there could be an oxygenation problem. So early signs, poor peripheral pulses, mottling, cold extremities, low urine output, altered mental status. And then I want to talk about the blood pressure and vasoconstriction with blood pressure and how that really is an early sign. And it's not a drop in blood pressure that's an early sign. If my systolic blood pressure starts to drop, now I'm in trouble. That's a late sign. But remember, kids are going to maintain a blood pressure with tachycardia and vasoconstriction. So as long as they have a high heart rate and they are vasoconstricted and I have those poor peripheral pulses, it's keeping their blood pressure up. So I need to look at a different way to evaluate that blood pressure to account for hemorrhagic shock. And what I'm going to look at is peripheral vascular or systemic vascular resistance. So if I know we're vasoconstricted, all my vessels are tight. So my heart is going to have to push really hard in order to get the blood from the left ventricle out into the system. And if it's pumping really hard, that means my diastolic pressure is high. And so my patients with compensated hemorrhagic shock are going to have a narrow pulse pressure. To do that pulse pressure, we're going to take the systolic blood pressure minus your diastolic, and that's going to give you a number. That number that you get is greater than 25% of your systolic. Now you have a narrow pulse pressure. And I'll show you what I mean here in a minute. Because what we're looking at with that diastolic, remember, is that high afterload, that increased systemic vascular resistance, the fact that the heart has to push really, really hard. And so an example of this, I have a 3-year-old who comes to our code room with visible seatbelt signs and abdomen. So if I put him on the monitor, we get some blood pressure, heart rate. Obviously for a 3-year-old, this kid is tachycardic, and you can see he gets more and more tachycardic over this 45 minutes that we're looking at him. And if I do a blood pressure every 15 minutes, his systolic blood pressure actually looks decent. I'm not unhappy with it. Now, if I put my diastolics up there, again, these are not blood pressures I am unhappy with. It's not a blood pressure where I would call a physician or I'd be panicking and want to get fluid just based on these numbers. But if I do the math, systolic minus diastolic, and I get a pulse pressure, you can see that to evaluate this clinical picture now gets really different. So I start out with a pulse pressure of 38, which is fine for actually a kid this size and with the systolic blood pressure. But you can see as time goes by, he gets a little more tachycardic, and where between 8:15 and 8:30, my diastolic or my systolic doesn't change, but my diastolic goes up. So what that's telling me is that I have more systemic vascular resistance, or I have more vasoconstriction going on. And the compensation my patient's having to do is getting harder, higher and higher. Now, the third thing that really kind of gives us some clues to hemorrhagic shock is the glucose level. Now, we may get kids into the code room initially and they have a high glucose level and not terribly abnormal, but that glucose level is going to plummet quickly. And the reason that happens goes back to that lovely Krebs cycle. Remember, if I don't have enough oxygen to meet my demand, then the Krebs cycle doesn't happen and I only produce 2 ATP. Well, my body's saying, well, my cells need a whole lot more ATP than that in order to stay healthy and work and do everything that they need to do. So we reach into our glycogen stores and keep pulling out glucose molecules to break down to get ATP. And so if that initial bump in glucose is because we're pulling from glycogen stores, but kids are going to very quickly run out of glycogen, and we're going to have decrease in glucose. Another sign and symptom that we're going to see in kids in hemorrhagic shock is tachypnea. That tachypnea is a result of the metabolic acidosis that these patients have because, again, that Krebs cycle, when you only have 2 ATP, you get that little lactic acid bonus. So as we start building up lactic acid, we become more and more acidotic, and we try to compensate by tachycardia in order to breathe that CO2 off. This is actually a very early sign. And some of the earliest signs that you can find in the literature of hemorrhagic shock are going to be increased respiratory rate and that narrow pulse pressure. And so these are things that we can't ignore. Now, as far as fluid shift as part of our compensatory mechanisms, this one's a little more delayed. Where fight-flight happens right away, fluid shift may take a little bit longer. And so for those of you who work in the emergency department, you may or may not see the result of fluid shift, but for those of you that work on an inpatient area, this is something that definitely will start happening once these kids get to you. And so what we're looking at here with my little boxes on the right is that 2/3 of all of our total body water lives inside of our cell. The other 1/3 lives in our extracellular space. And that extracellular space, just a very small part is made up of what is intravascular. And the rest is all of the interstitial fluid in our body, or all that fluid that goes around our cells. And so our body is programmed that when the vasculature empties, that these little areas are going to fill in and compensate. So a lot of things happen in that vasculature. We're going to give fluids, we're going to give meds, but we're also going to bleed from there. We're going to get labs from there. So if that vasculature empties out, fluid from inside the cell and around the cell fill up that vascular space so it's never empty. Well, the problem with that is that it's plasma that goes from the cell and the interstitial volume, and it doesn't contain hemoglobin. So even though we're able to keep our vasculature somewhat pumped up, it's being pumped up with things that aren't going to carry oxygen to our tissues. And because of that, we're going to see a drop in H&H. So when your hemoglobin, your hematocrit drop, it's not necessarily a number that's moving, it's a dilution problem from the plasma filling up the vascular system. And so that kind of gives me a little piece of trivia. I don't know if people know this. It was one of those aha moments the first time I heard it. And now every time I look at a CBC, I do the math. 1 hemoglobin equals 3 hematocrit. And every time you look at an H&H, do the math, and it's right. So let's kind of stop and put the puzzle piece together, what we're looking at right now. So we have a bleeding patient, so a kid with low hemoglobin. They automatically become tachycardic and tachypneic. They have a narrow pulse pressure, decreased blood flow to the extremities into your solid organs. They quickly go into metabolic acidosis. And then the last part of the puzzle, if you remember the trauma triad of death, they have problems with coagulopathy. And so all these things together kind of lead us to the fact that we have a patient in compensated shock. Now, when we take compensated shock and it moves to uncompensated shock, what is really happening is now we've had blood loss of more than 25 to 30% of our total blood volume. This is also going to what's going to happen when we lose this much blood is your pH is going to go below 7.20. And anytime your pH goes below 7.2, you're going to lose vascular tone. So all that fight, flight, vasoconstriction that's going to happen is going to go away. And that vascular tone is going to become limp. And now we don't have that systemic vascular resistance in order to hold your blood pressure up. So these kids are going to get hypotensive. They're also going to get bradycardic, again, to add to that hypotensive picture. And obviously you will have lost central pulses. Treatment that we want to do, and hopefully we are able to do this while they're still compensating, is we want to identify the location of the bleed, we want to stop the bleed, and then we want to refill the vascular system. Sounds pretty simple, but it definitely is a little bit harder than those 3 lines on the slide. We'll start by doing a physical exam of the patient. This is touching, looking, feeling. Is there bruising? Do they have peripheral pulses? Do they have deformities? Other ways to identify our bleeding is imaging. We could do CT or CTA, X-ray, fast exam. And then of course we have labs that we can look at, our H&H to look at that fluid shift, and even our liver enzymes kind of point us to the fact that we may have a solid organ injury. I want to spend just a couple seconds talking about FAST. FAST is a focus assessment with sonography. And FAST is something that the adult world has been doing for years and are very comfortable with. And almost every trauma patient that comes in gets a FAST exam and an ultrasound to their belly. The goal of that FAST is to see if there's fluid in the abdomen. It's not going to tell you it's blood, it's just fluid. As far as pediatrics, are we going to do this on everybody? Absolutely not. But what we may do is look at it on stable patients. Now, the reason we don't use this in pediatrics like they do in the adult world is because in January of 2016, there was finally a really good pediatric study that was done to look at the reliability of FAST in pediatrics. And it was shown with a high number of patients that we got a lot of false positives and we got a lot of false negatives. And so most of your children's hospitals are looking at FAST exams, and where we may do them in an unstable patient, just on the chance that there might be some fluid, we're not going to do these on most of our kids because your surgeons really don't put a whole lot of confidence in the results that they have. Now, here's an example of a kid that we have done fast on, or a type of child we have done fast on. This is a child that presented with bruising to the abdomen, but also came in with a head injury. GCS was 4, right pupil was sluggish, and the left pupil was fixed. Well, neurosurgery wanted to take her to the OR, but they didn't want to take her to the OR if she had bleeding someplace else. So it was emergent to get this kid, I believe she had an epidural, where it was emergent to get her to the OR, they didn't want to spend time in CTing the abdomen, so they did a fast exam just to look to see if there was any fluid. And so there was none, and they were able to get her to the OR. Now, once we recognize the bleeding, we got to stop the bleeding. Now, when it's obvious, the treatment is pretty obvious also. You know, pressure, maybe put a tourniquet on in order to get it stopped until we can get the right people down to do whatever procedures are necessary. But in the internal bleeding, it's a little bit harder. For kids with potential pelvic fractures, we may use a pelvic binder. That pelvic binder is going to kind of close up the pelvis back up and help those vessels in that area kind of tampen out itself. With a femur fracture, potentially we'll put them in traction, whether it's a hair traction or a bucks traction. This is as much for comfort as it is bleeding until they can go to the OR. And then we're going to keep them warm. And I know keep them warm doesn't necessarily sound like something that would be terribly helpful with a bleeding patient. But if you remember the trauma triad of death, hypothermia makes coagulation slow down. So if we keep these patients warm, we are going to help with the bleeding issue. And so things we can do to keep them warm. We need to make that room tropical. And I know our code rooms are not warm. I have tried for years to make them warm, and I don't know how, and neither does Biomed. But for those of you on the inpatient side, this is definitely something that you guys can do. We use bear huggers in the emergency department. In the code room, we have every trauma patient that comes through with an underlying bear hugger. And that was really based on helping with their coagulation when we made that decision. We can use the hotline in order to warm their fluids. And of course, we can put blankets on. And for those kids in the code room with the underlying bear hugger, having that underlying bear hugger and then blankets on top really helps keep that heat in and around that child. Now, some of the treatment for hemorrhagic shock is that these kids need to go to the OR and they need to go now. If we have a case of emergency OR, our goal is to get to the OR within 30 minutes, and that does include CT time. And so it's kind of a time challenge. Examples of some of our patients that go directly to the OR from the code room, quickly, unstable gunshot wounds to the chest or the abdomen, and maybe not even gunshot wounds, let's call it penetrating wound to the chest and abdomen. Unstable bleeding of the split of splenic or liver injuries, an unstable perforated bowel, and then obviously an unstable TBI with brain activity. Now, the goals of emergency surgery are not to fix everything. The goal of emergency surgery is to stop the bleed. If we kept those kids in the OR to repair everything and do definitive repair, they're not going to do well, because remember the trauma triad of death. They're cold, they're acidotic, and they're coagulopathic. So what needs to happen is they need to go to the OR. The surgeon needs to plug that hole, sew up that hole, stop the bleeding. They'll then go back to the ICU and get warm, get their pH to normal, and reverse that coagulopathy, and then they'll go back for a definitive care. So with that, let's go ahead and look at treatment of our patients who arrive in hemorrhagic shock. You need to replace the volume, and I have a picture of sodium, normal saline up here, and lactated ringers. Those are your isotonic crystalloids that we use for fluid boluses all the time. But we do not really want to use these with kids with hemorrhagic shock. There's lots of literature out there that tells us to avoid crystalloids at all costs with bleeding patients. First of all, we know that large amounts of crystalloid are going to enhance that inflammatory response. If we enhance that inflammatory response, we're going to see a whole lot of bad things happen on the back end. We also know that saline and LR do not carry oxygen any place. And so giving a bunch of crystalloid is not going to help us oxygenate our tissues. And that's a really important thing. So if you are throwing a bunch of fluid in, our body is trying really hard to clot itself off. That fibrinogen and your platelets are all moving to that area to help fix it on our own. And if I have fluid going up against those vessels, those clots are going to pop and we're going to continue bleeding. And then, of course, if you give a lot of crystalloids, a lot of normal saline, a lot of LR, you're going to cause a lot of edema. And if we go back to just the water in our body, if I infuse 1 liter of normal saline, only 1/3 of it is going to stay in the vascular space. The other 2/3 is going to fill the interstitial space. So really, I'm going to get less than 1 cup of intravascular volume for every liter that I infuse. And because so much of that saline or LR is going to go in the interstitial space, if I give several boluses of normal saline or LR, my kid's going to start looking like the Michelin Man, and they're going to puff up and still be intervascularly dry. So what we really want to use to replace blood loss in a kid with hemorrhagic shock is exactly what they're losing. We want to replace them with whole blood. And we don't have any whole blood, and so what we're going to do is component therapy. And the fastest and easiest thing for us to start with is O negative. The beauty of having O negative readily available is that is an oxygen carrying fluid. Now we have our blood refrigerators now in the code room and in CICU that can be used for any of the ICU patients. So we always have 2 units of O negative or O positive blood always available and can be quick to give. Now the advantage of PRBCs, it's quick, it carries oxygen. When you give packed cells, what you put in the vessel stays in the vessel, unlike your normal saline, which is going to go across those barriers. The other advantage is we can give it fast and we can give it warm in order to help with the hypothermia. Now, if we give a lot of packed red blood cells, we have to also remember to watch the calcium. That CPD that keeps the blood from clotting in the bag, it kind of eats up our calcium. And so it's something we kind of want to watch, because if we drop our calcium, that's going to interfere with our body's ability to clot. If we decide we're going to use those emergency cells, we probably want to think about ordering a massive blood transfusion. Now, our patients that are hemorrhaging are losing whole blood, so we have to replace whole blood, and we do it through component therapy. Here at Children's, we do packed red blood cells as pack A, and then a combination of PRBCs, platelets, and either plasma or cryo as part of pack B and pack C. The reason we do that is I think of it as mustard and ketchup. If you want the perfect hot dog, you can't just put a bunch of ketchup on it and think you're going to be able to taste the mustard. Nor can you put a bunch of mustard on it and think you're going to be able to taste the ketchup. You need to have equal parts mustard and ketchup, so equal red to yellow of your blood in order for your blood to be able to do exactly what it needs to do, in order for it to oxygenate and in order for your blood to be able to clot. If we have too much of the red, we're going to continue to be coagulopathic. We have too much of the yellow, we're going to dilute out all of our oxygen carrying capacity, and so that's not going to be good. Now, FFP or plasma is a wonderful thing when you have low preload, which we do in hemorrhagic shock, so you have an empty vascular system, and you need to fill that tank back up, because FFP, whatever we give, stays in the vascular. So if I give 500 of plasma, all 500 is going to stay in my circulating volume. Also going to help improve our clotting. And again, it's something that we can give warm and fast. Now, the problem with plasma, as we all know, is it takes 17 to 20 minutes to thaw. And when you have a hemorrhaging patient, 17 to 20 minutes is an absolute eternity. And so it's one of the reasons we have to think to activate massive blood transfusion protocols earlier versus later, and then cancel if we don't need it. I will share with you that the blood bank is working on having thawed plasma available. And so hopefully this problem will be a thing of the past by the end of the year or somewhere into 2021. Now, another problem with plasma is the universal donor for plasma is AB, unlike blood, which is O negative, and AB is even more rare than O negative is. So sometimes what you will see is you will get plasma that's either A or B, not often just AB. So again, order early so we can get it fast. And then, of course, platelets are part of our massive blood transfusion protocol, and they're going to help with our coagulopathy. And if we didn't give platelets, the packed cells and the FFP would dilute out whatever platelets we have in our body, and we don't want that to happen. And platelets are part of pack B and pack C of our massive blood transfusion. Now, something to keep in mind with platelets is we can't warm them and they shouldn't go through a pump or a rapid infuser. We kind of have to baby them a little bit. Now, there are some places that do use whole blood. Friends of mine in Pittsburgh have been doing whole blood transfusions on their trauma patients now for a couple years. And they've had really positive outcomes, and they've been published, and you can see their publication here in JAMA Pediatrics. And I believe they're up to giving 3 units of blood before they go to component therapy. And part of having to have a max is because of the potassium problems that you can see. Now, another part of massive blood transfusion that I'm just going to hit on, and this could be another lecture all in itself at another time, is the use of TEG, or thromboelastogram. TEG is a blood test that we can send to the lab. Actually, it goes to blood bank. And the result of it helps us guide our use of blood products, and it helps us make the decision, do we want to continue giving TXA, which I'll talk about in a second. So what's going to happen with TEG is it's going to take the blood and it's going to look at the clotting, the lifespan of a clot. From how long does it take the clot to form, to how strong the clot is, to when it starts to lyse. And based on the diagram that you see and what it looks like, it tells us give FFP, give more platelets, give TXA. And so it really could guide us so we don't have to just be guessing with that massive blood transfusion 1-to-1-to-1 protocol. Now, there are some problems. We do have TEG available here at Children's, and it's not a perfect system, but it's baby steps and we're getting there. So right now, all of our trauma set attending activations or any hemorrhaging trauma patient should have a TEG level drawn. If we decide to do a TEG, the lab needs to be alerted that we're going to do this. And our number is 5676. And the reason being, it takes 30 minutes to warm up this machine. So you can't just send it and think they're going to be okay, because that blood's really only good for about 15 minutes once it's drawn, and if we want to get an accurate reading. If you want to do a TEG, it goes in a blue top citrated tube. You have to rotate the specimen and you have to walk it to lab. So you're going to walk to lab, kind of, you know, moving that tube back and forth to keep everything moving. So if that's not, there is an order for it in Cerner, and so it can be ordered under TEG or thromboelastic, easily found. Here's the big problem, is that the lab really only has the capability to run this test Monday through Friday, 8 a.m. to 9 p.m., and Saturday or Sunday, 8 a.m. to 3 p.m. And we all know that trauma patients come in the evenings and on the weekends, specifically weekend evenings. And so we have struggled with being able to really put this totally into our protocol until the lab can get their staff up and ready to do this 24/7. So more to come. Now, one of the things I said TEG is going to help us with is telling us, do we want to give TXA, or tranexamic acid? TXA, basically what it does is it stops the clot from lysing too fast. It helps with holding a nice solid clot together and keeping it together. And so TXA, it's actually pretty cheap. And if you don't need it, it won't hurt you. And so any hemorrhaging patient that you're concerned about, you may have physicians ordering TXA, especially in our code room. Initial dose is 15 milligrams per kilo, and we give it over 15 to 20 minutes. And then you follow that with an 8-hour infusion. And our pharmacists are a great reference, and we have a lot of good reference tools in the trauma manual and in the med book down in the code rooms. Again, TXA and TEG, we may just do another web talk about just those together, because that could be a whole hour talk. And the next thing we want to do is our kids need administration of the volume. And remember, the faster we give this volume, the better our kids are going to do. The faster cardiac output is restored, the faster they get oxygen carrying capacity or volume, and pH is returned to normal. And so it is all about volume and quick volume. We did a little, what I refer to as a science experiment one day, in which we took a liter of saline and we measured, we used a stopwatch to measure how fast we could infuse a liter of saline through different gauge IVs, using the push-pull method, using a pressure bag that we kept up to 300 and made it we kept pushing it up and made sure it stayed at 300. And then we also looked at it, a pressure bag, if we forgot to pump it back up to 300. And you can see through a 24 gauge IV, we're not able to give volume very fast at all. The fastest way to give volume through a 24 gauge is by push-pull. We can give a liter in 14 minutes. And if I give it through a pressure bag and I forget to keep it pumped up, it's over 40 minutes. Now, if we go all the way down, you can see the 18 gauge push-pull. I can push-pull in 8 minutes and 28 seconds. But if I have a pressure bag and I keep it pumped up, now we are able to give it in 6 minutes and 14 seconds. Now remember, this is normal saline, so I did not account for the viscosity of blood or blood products, which will take a little bit longer because they're thicker. Now with either of these mechanisms to infuse volume, remember we have to warm this fluid, and so we're going to have to be able to push-pull or do the pressure bag through the fluid warmer in order for our patients to get the max results. Now our other option is to use the level 1. Now level 1, really you need to have at least a 20 gauge IV or larger. Now remember, if I only have a 20 gauge, it's not going to go terribly fast or as fast as I want it to. But if I have a 16 gauge IV, now I can give a unit of blood in less than 2 minutes. So gauge does matter, even though we have these balloons pushing. Because what's happening with the level 1 is the balloons that are in each of the reservoirs, that goes up to 300 millimeters per mercury, just like our pressure bags do. Remember though, using that level 1, it does require user knowledge. It does require a dedicated person to be able to switch it out and to keep track of the volume we give. Unfortunately, there's a lot of times where we have kids in hemorrhagic shock and they're requiring a large volume of blood products, and we're getting it to them, we're giving it fast, and that's great, but we lose track of what we've given and we're not able to document it or to do handoff, and so we really are a little bit behind the 8 ball there. We have to basically use caution in giving this with young children, because remember, it's not measuring, it's just throwing it in. And so just buyer beware on that. What about epi? I see a lot of times in the code room, we have a patient come in with hemorrhagic shock, and epi seems to be an early treatment. And it actually makes me lose my mind because it's not really the best idea. Epi is a wonderful drug for kids who are in septic shock or neurogenic shock, but it's not really what we want in the early stages of the treatment of hemorrhagic shock. Because remember, epi is a vasoconstrictor, and epi is meant to increase afterload in order to keep a blood pressure up. For kids in hemorrhagic shock, they're already vasoconstricted. It's part of the shock mechanism. It's part of how the body responds to losing blood. And they already have a high afterload. So that epi is not going to really be able to be a benefit. Now, what we do see is that we give that code dose of epi, and we have this very transient response that lasts anywhere from 30 seconds to about 2 minutes. And basically what's happening is that epi hits the vessels, and it does give it a little bit of squeeze, but because the vessels are already so vasoconstricted, they can't maintain that extra oomph that epi gives. And so we quickly see them, we quickly see a response and then quickly see them decompensating again. Another treatment is to look at non-emergent OR versus medical management, or how are we going to take care of these hemorrhagic patients once we've kind of got them a little stabilized. So our first thing is we're going to look at medical management or non-surgical management if, one, they're responding to treatment, because several of our kids are going to self-tamponade. Anybody with a splenic or a liver injury or a kidney injury, those all organs are all encapsulated, and that encapsulated organ allows that organ, if it's damaged, it allows it to tamponade and kind of stop its own bleeding. The femur fracture we may see, they may not go straight to the OR, but they may want to wait till the morning because muscle contractions are so intense, it's really hard to do a definitive surgery. And so a lot of our patients are going to be medically managed once we get them past that initial stage. And if they're medically managed, that becomes your patient as the nurse at the bedside. And so as the nurse at the bedside, you're going to want to do frequent physical assessment, because what we're going to look for is, did the bleeding really stop? And if it hasn't stopped, we need to let somebody know. So with physical assessment, look, listen, and feel. Look for increased bruising. Listen. Can you hear the heart sounds? Can you hear breath sounds? Can you hear peristalsis? And feel, does that belly look tense or feel tense? Do they have pain when I push? And all of those are going to give us clues. Additionally, we're going to look at distal pulses. We're going to look at what their output is, their urine output is, and what their mental status is. It's part of that physical assessment to see, are we done bleeding? We're going to do frequent vital signs. If they're an ICU patient, these are kids that are on Q1 to Q2 vital signs. They're on the floor Q4 at the very least. What we're looking for is, are they done bleeding? If we see tachycardia that's unrelated to pain or fear, we're going to watch for that narrowing pulse pressure. We're going to feel that peripheral circulation. Again, assess that mental status and urine output. All these things need to be done frequently. You may have serial labs ordered. Those serial labs are going to watch for that fluid shift we talked about, that dilution of the hemoglobin because of the fluid shift from around the cells and inside the cells. And if you look at our solid organ injury guideline, patient with a stable splenic or liver injury, they're going to have a repeat H&H ordered 12 hours after they arrive, just to make sure that we don't have fluid shift. And if they're unstable, we're going to probably watch that H&H at least every Q8, and it may even be more frequent if we're required to give them blood. I want to talk a little bit about penetrating injury to the chest or abdomen. Our concern here is that there's a big old hole in the heart, a great vessel, an internal organ that's causing more blood to be lost than we can replace before we can get them to the OR. So we hear in the emergency room that one of those kids are coming in, and we have this poster, and I know it's very blurry, but I'll show it to you a little better here in a second. We have these preparation posters, both in code room 1 and 2, just to help staff remember exactly what it is we need to have set up, because let's be real, we don't get these kids every day, and it's a low volume, high risk type of patients. Now, things to consider when we're looking at prepping for these patients, where we have it outlined of whose job it is to do what. These are just suggestions. We can have other people in the room help get things set up. We also have to remember that Nurse Wright might be on the helipad, and so we're going to have to share the responsibilities between who's in the room to make sure that those Nurse Wright responsibilities are done. So if we look at it closely, basically we have assigned to Nurse Wright to make sure EKG leads and pulse ox probes are ready for application. We can put those on fast, that there's a CPR board on the bed, and that we have 2 Mayo stands and they're at the bedside. Now, Mayo stands sound like something pretty simple, but A, sometimes they're hard to find, but B, they're really, really important because the surgeons have to have some place to put the chest tube equipment on and the trauma line equipment on, and they can't be standing around just holding it looking. Nurse Wright also wants to turn the bear hugger on and get the cordis catheter out and put it on one of those Mayo stands. A cordis catheter is a single lumen central line that can go either in the subclavian or the femoral vein, and it's a nice big line that is wonderful for giving volume and giving volume fast. Nurse left, we're asking them to remove 2 chest tube bundles from the code room, have at least one of them open on the Mayo stand, so if needed, we can put a chest tube in right away. And we actually just had a kid come in last night who needed a chest tube. Really, that's all he needed, and it was good to have these ready. Their job is also to connect one pleurovac to suction, and that way when the surgeon gets the chest tube in, it's ready for immediate use. And we will ask them to move the surgical table with the open thoracotomy tray to the left side of the room. Put that by the medication table to allow EMS to get to the bedside. Now, you can see in this picture, this is code room 1. And if you look behind that computer on the other side of the blood refrigerator, that is the open thoracotomy table. So it is very hidden in the room. It's really important for nursing to recognize that that is there, because you have to remember our surgical residents are rotating. Other than our fellows who live with us for 2 years, surgical residents rotate, and they, even though we show them where this is and that it's there, they may forget. And so nursing in the room really needs to take responsibility for moving that to the left side. Now, the medication nurse, we're going to say, go ahead and prepare RSI meds. We ask them to get the IO drill and needles on the Mayo stand and place the code med tray on the counter. And then turn on and place a transport monitor near the stretcher, because we want to make sure that we are ready to move out of that room and get to the OR right away. And finally, the charge nurse removed the emergency blood from the fridge, and prime the tubing for immediate administration. Obviously, on older children, we'll use the rapid infuser, and younger children, we can do push-pull. We assign them the defibrillator to the bed and make sure the pads are ready to go. And we also assign to the charge nurse to remind the NAL and the leadership team in the room to order massive blood transfusion, order TAG, and alert the OR that we may have a possible patient. I just kind of want to take a few minutes and go through a hypothetical patient. This is an 8-year-old female. We get report that she is coming in with a single gunshot wound to the chest. Her GCS is 11 at the scene. She's tachycardic, she's tachypneic, and her reported blood pressure was 88/64. I'm gonna go back. So things we know about her right now. We know that obviously she's bleeding from something. We don't know exactly where the gunshot wound and what it's hit, but we know that there's a whole lot of important stuff in the chest. And so she's at a whole high risk for being in hemorrhagic shock. We also right now know that she's compensating because she is tachycardic and she's tachypneic. She also is somewhat still responsive. So she is getting some oxygen to her brain, but probably not necessarily enough. So anticipated care before she gets here, obviously we want to make sure she has access, and we probably do not want to mess around with trying to get a peripheral line. If you are vasoconstricted, it is not going to be easy to get a peripheral line, so don't waste your time and let's go straight to an IO, and we'll also have that Cordis catheter set up ready to go. Have the non-rebreather attached to oxygen so that can be placed right away and help oxygenate, keep her blood, what she does have, good and oxygenated. If she does come to you awake, if they decide to intubate, she would need RSI drugs and an Untitled line. If she is obtunded, we're not going to waste our time with that. Chest tubes. Likely because it's in her chest, we anticipate that she's going to need a chest tube. There's probably a hemopneumothorax. Cordis catheter needs to be set up. And we want to probably have packed red cells on the rapid infuser and have the massive blood transfusion activated. And then have the open thoracotomy tray to the left side of the room and ready to go. So this is a room that's prepared for about anything. And then finally, I'm putting on here antibiotic, which I know it's not life-saving, but for anybody with a penetrating injury, early antibiotic care does help with outcomes. She arrives to us and she's combative. Her GCS is now 8. She has 1 wound that is actively bleeding. She has increased work of breathing, and she has decreased breath sounds on the right. So again, what we know here, if she only has 1 wound, 1 hole on her body, we know that that bullet is probably still in there. She has active bleeding, she's losing blood. So where she is compensating right now, she's not going to be compensating very long. And we know that her ability to compensate is decreasing because her GCS is getting lower, which means she's not oxygenating her brain. And then just based on the work of breathing and breath sounds, most likely again a pneumothorax. And so it doesn't take a whole lot of information to figure out what's really going on. We get a manual blood pressure and she's 88/62. Her heart rate's 175 and her respiratory rate is 36. 88/62, not terrible. But remember, we're compensating, we're vasoconstricted and we're incredibly tachycardic in order to get there. So she is compensating, her body is working really, really hard in order to maintain that fast heart rate and maintain that afterload in order to keep that systolic pressure up. She's also with respiratory rate of 36, compensating for that awful metabolic acidosis she has. And basically what those vital signs tell me is that we need to move fast or she's going to quickly go into uncompensated shock. It's a priority of care based on this very little data. I would say, Nurse Wright, get them on the monitor. Don't mess around with an IV. Get a butterfly and just draw labs really quick because we do need a type and cross for the blood bank. We already have a working line that they can start putting blood in. And don't forget about the tag. Nurse Wright could also assist with Cordis catheter placement. I mean, basically what you want to do is make sure it's open, that the surgeon has what they need, and if you need to get anything for him or her, that's great. Most of this, the surgeon will take care of on his or herself. And again, PIV attempts, don't spend a whole lot of time because if you're that vasoconstricted, we don't really want to spend that time. Cordis catheter IO is where we want to go. Nurse left, if she does come in with an existing IV, go ahead and check the patency, and if it's working, we can start infusing blood right away. And we have seen several times that kids have come with hemorrhagic shock are coming in and they have an IV that EMS placed and that it's a good IV. And we spend time getting a second IV because they want to save that first IV for meds. Do not save it for meds. Meds are not the priority. Blood is the priority. And so use that initial IV. We can give meds through the next access we have, or we can interrupt the blood if we need to give something fast. Nurse Life, continue doing a manual blood pressure, because if you are in compensated shock, we all know that that Dynamap or that automated blood pressure, it's not terribly accurate. And that manual is going to be a whole lot more accurate than what we're going to see on the screen. And then identify somebody to help run that rapid infuser or push-pull, because Nurse Life, we want you to be freed up in order to monitor responses, to give antibiotics, to give any drugs that are needed, and to possibly assist with chest tube placement or any other surgical procedure. As far as other priorities, chest tube insertion in this child is going to be a priority. We're going to do this potentially ahead of intubation, as intubation may not be necessary if this actually fixes the problem. The kid who came in last night ended up not being intubated. We were able to put a chest tube in, and the kid started oxygenating much better. Nursing role setup, Mayo stand. Make sure they have a Mayo stand in order to put that chest tube in. And then our role as a nurse is handing in the connection to the chest tube and putting it to suction and document that initial output. This is really important, as I need to know, what does that initial output look like? Is it bloody? Is it serosanguinous? And how much of it dumps? Because that's going to give us some indication of how much they've already bled. And then, of course, if we need to intubate, if you only have one line, we can interrupt that blood for a second to give RSI drugs. Hopefully, we'll have gotten that cordis catheter or an IO in, and we can use that instead. So a few minutes go by, right chest tube is in place, and it jumped 200 mils bloody drainage. Your patient remains tachypneic, but not as labored. Red blood cells are infusing through the rapid infuser. Her GCS has increased to 10. Her heart rate really hasn't changed. And her blood pressure is 84/60. A cordis catheter was placed, and she has no additional injuries other than this gunshot wound with pneumothorax. Now we have to look at now what. Now, I think I can speak for all of us. None of us are happy with a heart rate of 174. And we've talked about pulse pressure. And so we know, even though that at first glance that looks okay, our pulse pressure is still pretty narrow. So we're going to continue to give volume based on those vital signs. And then the team may consider an emergent OR for her. Now, the decision to intubate, if they decide emergently to go to the OR and she's not intubated yet, they may choose to intubate in the code room, or they may choose to go up to the OR and intubate up there. And that's something that the anesthesia will talk to the surgeons and make that decision. Now, if we need to move quickly to the OR, we have developed an emergent OR packet that lives at the NAL station. And this is just the first page of it. It's a 2-page packet. It has, or I guess 3 pages. It has instructions for the NAL, who to call, what to say. It has instructions for the resident, who to call, what to say. And it also has surgical consent that can be signed. And so we're ready to roll out. This kid goes into PEA. We're unable to get a blood pressure. We have no central pulses. We're going to begin CPR right away. Anesthesia is going to intubate. There's no meds necessary because she's obtunded. And we're going to continue to give warm volume. So continue to go down the packs with a massive blood transfusion. The surgeon is going to quickly want to open the chest because this is somebody that we visualized going down. We need to make sure that open thoracotomy tray is on the left side of the bed. It's going to contain everything they need, the betadine, the blade, the open thoracotomy pack, absolutely everything they need to open it. Both surgical residents, your surgical coordinator and your junior residents, are going to go on the left side of the bed. The junior is going to help pass instruments in because none of us are scrub techs and know what any of that stuff is. And then a scrub tech should be called to come down. You can see the open thoracotomy tray now on the left side of the bed here. The goal of the emergent open thoracotomy is to close the hole. And it's really important as they're looking to either suture, staple, put a finger in it, put a Foley in it, whatever, in order to close that hole and stop immediate bleeding. It's important that we keep giving blood products. The other thing they can tell us what the heart looks like, if it looks empty or if they have enough volume in there. Now, when do we do an open thoracotomy? You can see if they have a penetrating extrathoracic or a penetrating thoracic wound and they have signs of life, or blunt signs of life, then it may be an indication for an open thoracotomy. Now, signs of life are hard signs, pupillary response, spontaneous breathing, a carotid pulse, a palpable blood pressure, electrical activity. And we're not going to do these open thoracotomy if they've been down too long. If they've been down for greater than 15 minutes pre-hospital with penetrating, we won't even go there, or 10 minutes with blunt. So with this kid that we're opening up, we need to be ready to mobilize to the OR at any minute. So get that transport monitor on the bed, and remember the rapid infuser only works on battery, so you'll need to keep pushing and pulling. On nights and weekends, if we're taking somebody emergently to the OR who we're having to push volume on, the OR is working with the skeleton staff, and so they may or may not have enough resources in the OR to be pushing all that, and may ask for somebody to stay until the anesthesiologist is ready to take over giving volume. So that takes us to 2:01. So I apologize for going a minute over. And if there's any major questions, I don't know if Cindy has wants to do any more, but I can take those now.
There's no questions on the chat at this point.
Okay. My email's on here, and so if you have any questions, comments, be happy to hear from you. And thank you for joining us today. I really appreciate it, and have a great day.
And before we get off, I just want to make sure that everyone notes that the link is in the chat section. This is the only way you can get the eval link. I'm going to put it in one more time so everybody has a chance. Make sure to use a Chrome browser when you are accessing the link. Have a great day, guys. I'm glad you enjoyed it.